We're recording this on an August day in 2022. Dr. Alan Ward, the third generation of Ward, serving Worcester for nearly 100 years, and we are going to review your family history and their practice and their contributions to medicine in Worcester. So there we are. That'll give us something to start with. And why don't we start talking about your grandfather, Roy?
Okay. First of all, you got to realize that when I was born, and I'll mention this later, I lived with my grandparents' ward a lot because of my father's battle with tuberculosis. But so I spent a lot of time. I saw, from early childhood up until I went to medical school, seeing what his life was and experiencing that. But of course, in those days, never had any idea that I would be sometime interested in the nuts and bolts of what he did. So a lot of it is just stuff I overheard. At any rate, my grandfather was born in, this is Roy Jocelyn Ward, was born in Johnson, Vermont in the mid 1870s. And from there, he went to Dartmouth College in Hanover, New Hampshire, graduating in the class of 1897. Happens to be the same era as Robert Frost, although I never thought to ask him about that either. And then from there, he went to Dartmouth Medical School and graduated from there in 1900. It was a 3-year school then. Now, in my reading about becoming a physician in that era, it seemed to me that this was a fairly sophisticated education, that so many doctors of the 1800s learned their trade by being an apprentice of some sort, some with only a high school education. So my grandfather had not only a college education, but a medical school education. And then I have upstairs, I have all these diplomas from his era. And I've got a diploma from the postgraduate program at Mary Hitchcock Hospital in Hanover. Mm-hmm. So it was really in that and Harvard and probably Hopkins and some of the other long-standing schools had a much more sophisticated approach to healthcare training at the time, considering what there was available. At the same time, it was interesting because I also heard an aside one time that perked me up, and that was his going out on the train and picking up cadavers for the medical school. And this was going up through northern New Hampshire and Vermont, not grave robbing that I know of, but finding people who'd committed suicide and the bodies donated to the medical school. And I thought that was pretty interesting. When he graduated from his program at Mary Hitchcock, he set up a medical practice in Brookline, New Hampshire. That's just over the border from Lowell, I think, in that area, in Lowell, Massachusetts. And he was only there 3 years, and then he went to Worcester. And the only comment I heard was that he was told by his doctor, he never told me he was ill, but he was told by his doctor that he should move to the city where you wouldn't have to work so hard, which he did. So he moved to Worcester, and his first office was on Pleasant Street. And he was there for a few years. And I think around 1912, he moved to the office, which is still there on Bellevue Street. So he started his office in a two-family house on Bellevue Street. that he turned part into his home and the other half into his office. And then subsequently, sort of emulating the Fallon Clinic, he thought it would be a great idea to have a clinic. And so he set up a number of offices, joining his house and office with the three-decker next door. This happened, and a lot of the doctors we know, like Fawzi Palwan, Bob Maloney, and so forth, Stan Shykowitz, were in that office. But this never evolved beyond just office space. But it was very pleasant, and while City Hospital remained open, it was a very handy facility to have.
I'm not too familiar with the geography there. How far was this office from City Hospital?
Well, you walk, Bellevue Street came out where Muir's Laundry was on Pleasant Street. Not Pleasant Street, on what's the next one? West, south of Chandler Street.
Mm-hmm.
So on the corner. So that was, so the office was maybe 200 yards from Chandler Street, and then you just walk up King Street to City Hospital. Let's see.
Well, there were a lot of, if I can comment on a couple of observations, just to supplement what you said, you're absolutely correct regarding the quality of the education he received. To give you some perspective, before 1850, around 40% of doctors hadn't attended medical school. And among those who did attend medical school, there were no pre-medical requirements, and many were not even literate. So in the 1860s, Harvard Medical School, there was some reluctance on the part of the faculty to require pre-medical education, because they said that roughly half to two-thirds of the students could not read and write, and they were just giving them oral exams. They made the switch, and they actually lost enrollment. Then Johns Hopkins came into being around 1792, just before, or around the time your grandfather was going to medical school, and that model served as an example for the rest of the country. And there was a review of every medical school in the United States and Canada that was done roughly around 1910 by the Carnegie Institute, Carnegie Foundation. And that was a very critical look at the various medical schools that led to the closure of a high percentage of medical schools, and the revision of the curriculum to requiring an undergraduate degree and 2 years of medical school being basic science and 2 years being clinical, and an affiliation with a hospital. So your grandfather was stepping into the career in the middle of all of this happening, and he was on the right side of it. He was on the more progressive side of it.
Dartmouth Medical School is one of the oldest medical schools in the country also. As far as I know, I have didn't bother to look up when it was founded. But anyhow, my grandfather's, he did a general practice. He did obstetrics and he did general medicine out of this office. And as I had mentioned, he'd been in that neighborhood, and so he took care of an awful lot of people in that neighborhood. And in fact, they say Worcester's the three-decker capital of the world. The fact is that in those days, three-deckers were a sign of prosperity, that you owned part of it and you rented out the other part. So when I was little, there were some pretty nice cars. Like my grandfather had a pair of matched Packards in the late 30s. So, it was interesting. But my grandfather, among other things, was the school doctor. And he was, I had heard, the scourge of the farmers over pasteurization. and the pasteurization of milk. And I had my father's had a brother who died at the age of 3, and I'm wondering if this had something to do with some bovine
TB.
disease,
Yeah.
like TB or something like that. I have no idea. It was never mentioned. It's a question I never had, but he was sort of a bully. I heard about that. Uh,
Well, the other piece here, just to let you know, is that Roy Ward was very active in the Worcester Medical Society, and it was an effort on the part of the whole medical society. So he may be have been the one who incited it to happen. But there was a doctor's campaign to get pure milk for the babies because the infant deaths were going up in the summer
right.
in Worcester, and so there was an effort which I believe continued for a couple of decades. Um, so yeah, he knowing how active he was in the medical society, he probably was behind a lot of that.
Yeah. He was in the service in World War II. I heard nothing about that. I think he was stationed in Boston, and this was, of course, also during the pandemic of that period. But I remember finding his uniform in one of the trunks in his garage after he died.
So you mean World War One?
Yes, I said
Okay,
World War One. Yes.
okay.
Uh, he was, as you said, very active with the medical society. He was president for a few years, a couple of years in the 50s. But what I remember, among other things, was that he was always available. His office door was on the other side of his dining room table, so could be the middle of Christmas dinner, Thanksgiving dinner, or anything else. If the bell went ding dong, he was gone into the office. And we never went anywhere without doing a home visit, which is
Mhm.
often followed by ice cream, sort of to lure us. People didn't have phones, and so he and my grandmother had separate bedrooms. And I presume the reason was that patients knew where his window was and would throw pebbles at it at
Oh
night
my.
to,
Uh-huh.
to get his attention. Uh, one of the things I remember very, very well was going with him to the Medical Society offices when they were on Cedar Street.
Hmm.
And as just a young kid, and seeing the collegiality of the people there, doctors from all other hospitals. They were reading papers, they were discussing cases, and so forth. Something that is not part of Worcester medicine now, for sure.
Hmm.
And as far as hospitals affiliation goes, I think his main affiliation was Worcester City Hospital. I don't recall seeing him anywhere else, but it could have been. As you said, was helped with history. One of the things I learned early on was that when Worcester City Hospital wanted to institute a medical records system, he was adamantly against it. And when they cleaned out his office, one of the things he had was filing cabinets of 3x5 card, actually 3x4 cards, those little like
Yeah.
with the patient's history on it. That was it. My
Uh-huh.
father went to 5x7 cards, but so anyways, he more or less worked until he died, and he died at the age of 89 in I think 1964.
Wow.
So he had a long career. The other thing I remember is that people, and this of course was before Medicare and all that, and insurance, that he had uh, uh, took a lot of things in kind.
Hmm.
He had some Chinese patients, and he had all kinds of Chinese knickknacks in the shelves in his house and stuff like that. So you would say, I really wish I had paid attention and listened to him and my grandmother. You know, long gone, unfortunately.
But what a remarkable life, because, his career started at a time when medicine was just becoming an educated profession and progress in medicine was just taking off. He practiced medicine at a time when they were just introducing x-rays, when, decades before they had antibiotics, and managed to experience the golden age of discovery and advances in medicine for his career. What a,
I do have to add one other recollection was that, as I said, I spent a lot of time staying at their house, and
yeah,
they were next to the Winslow Street fire station. And in the middle of the night, the siren would go off, and I would levitate out of my bed and run downstairs. And I swear, I never failed to see my grandfather sitting in his chair reading medicine.
yeah,
He, and he was very, I just remember the New England Journal was part of my life.
yeah.
I could recognize those things. So that was interesting.
It is
Uh,
terrific.
And
And
there was one other relative up there, and that was my grandfather's brother-in-law, who was from Hanover, New Hampshire, who ended
mhm,
up practicing medicine up in Littleton, New Hampshire. He's the one I told you used to make home visits in the snowmobile, uh,
right.
the Model T snowmobile. So my dad, you want to go on to him?
Yes.
Dad, Arthur Downing Ward, was born in 1912 at Worcester City Hospital. He graduated from Dartmouth in 1934 and from Tufts Medical in 1938. Uh, he did a post, pardon the phone, he did some postgraduate training at City Hospital when he contracted tuberculosis.
Hmm.
And when I was a baby, he was in the sanitarium at Worcester, at Belmont Hospital.
Right.
And so my mother and I lived with one set of grandparents, then with another, and back and forth, which is why these memories. This was before antibiotics. And so he was treated, as I told you, with a pneumothorax therapy. And then after he recovered, the draft was on for World War II. He was not draft eligible, but because of his status as a physician, he was made the chief medical officer at Belmont Hospital. So he was able to oversee the infectious disease part of the hospital, and had a lot of contact with people like Dr. Overholt of the Overholt Clinic and so forth, who was doing thoracoplasties, removing ribs for tuberculosis, things like that. So he was well familiar with that. And we ended up living in the 3-decker on the campus of of Belmont Hospital, right on the corner of Oden Ave and Belmont Street, still there. So I spent a lot of time, the people at the information desk at Belmont Hospital used to babysit for me. So my dad would walk me up and leave me there while he made rounds. And it was an interesting way to grow up as a kid, my grandfather always had patients, and we were in the hospital all the time. So that was a interesting experience. Dad, his career was largely included his tuberculosis contacts. So our office on Bellevue Street included an early X-ray machine. And I always wondered how much radiation my secretary got from that machine, but she didn't seem to be affected by it. Dad worked primarily out of Worcester City Hospital, Hahnemann Hospital, and Fairlawn Hospital were the primary places he worked, but also was involved with TB patients as they appeared in other places. He took over the Getchell Clinic. I don't know when Dr. Getchell died, but it was always the Getchell Clinic. Now it's the Getchell Ward Clinic. And in fact, my granddaughter, who's a physician now, while she was a student at UMass Medical, tested positive for TB and ended up a patient at the Getchell Ward.
Oh my.
So she didn't see the connection then. My dad was the treasurer of the Medical Society for many years.
Yep.
And he died in 1996 with cancer of the pancreas. So his tuberculosis, which we was certain would shorten his life, had really he lived to be 84.
Mm-hmm.
So, and he, I think, had a great experience, is hugely well thought of. He, like my grandfather, did home visits continually.
So growing up with him, beyond the span where he was at Belmont Hospital, what, do you have many memories of, him going to his office, going on rounds with him, going, dealing with interruptions or anything like that?
As a kid, he once I got to be big enough, he would, if he had a problem in the night, he would get me up and we would go out and lift people off the floor and so forth. Also, the first case of labyrinthitis I saw as a 10 or 12-year-old kid. It was up on Pleasant Street beyond Tatnick Country Club in the market. The owner of the market was lying on the floor with his feet going up the wall. And I was so astounded. And so Dad explained it to me. So I had a lot of exposure that way, and I think I told you, would hold heads for him when he was doing rigid bronchoscopies. We used to go up to Fairlawn hospitals on Saturdays, and I would hold heads for him. And I told you I'd go on house calls with him at night and sit in the car and study while he saw patients. And then he'd let me drive long before I was eligible to drive. So that was a great time.
Was he, did he have much time to spend with the family? Was he tired a lot? Did he,
He never seemed tired. And he loved his workshop. So he and I built a boat, and he taught me to sail and all this stuff. My brother, not so much, because my brother was always chasing girls. So that was not my interest particularly, but I remember nothing but good things about that. And yes, things were interrupted by, we'd come home from a vacation, camping, and the phone would ring and he'd change his clothes and go off and do a house call. That was
sure.
So that for me, when I started my own practice, I tried to avoid this to sort of save my marriage, but also it was not something that was a surprise to me.
Yeah. And did he carry a beeper, or was that something that was introduced?
That was another thing you and I talked about the other day, that my mother, the bane of my mother's existence was, in those days, it was all by telephone. My mother would, every morning, my dad would give my mother a list of the phone numbers of where he was going to be, hospitals, nursing homes, patients' houses. And if certain times she would start, if people called, she would call these places. Has he been there yet? Yes or no, and so forth, until she tracked him down. This happened every morning, 5 days a week. I think it really didn't please her a lot, but there was nothing you could do about it. People
Hmm.
didn't come on until I was in residency, I don't think.
Yeah.
Yeah.
Okay. So, excellent. And he had less interest in history than your grandfather did.
Oh, as I told you, he just, all this stuff, he just chucked.
Hmm.
And for instance, Dick Danford, remember Dick?
Yep.
Radiologist. He wanted my dad's X-ray selection because there were incredible films of TB in those days,
Sure.
and that all got chucked too.
Oh my.
That
Okay.
that's all history over the dam.
Yeah. Yeah. Okay. That
And
brings us to you.
yeah, well, I was born in 1939 at Worcester City Hospital,
Hmm.
and went, as I said, had a lot of exposure to medicine. However, it was not any way a pressure to go into medicine, but it was so familiar, it was pretty easy. And so I uh, graduated from Dartmouth in 1961 and went to Tufts Medical School. In 1965, I graduated. And my wife says, "Why did you go to Tufts Medical School?" I said, "I have no idea. It just was where he went and it worked for him." So my field was internal medicine and medical oncology. And when I came to Worcester in 72 and joined my dad in my grandfather's old office, um, I was the second oncologist in town. Herb Dean was the other. And Herb was pretty much, I think, exclusively at Fallon Clinic. So I ended up covering the rest of the city. So a day would sometimes include 6 hospitals racing around to do rounds. I also spent 2 years in the Air Force. I was drafted and stationed in Washington, D.C., and ended up working with Peter Levine. And Peter knew of my interest in oncology. So since he was a hematologist, we sort of did some oncology while I was in the Air Force, which was an interesting experience. So
And what year was this? When were you in the service?
60, let's say I went in 67 and got out in 69.
Fine. Okay. So you were stateside during the Vietnam War, though.
Uh, I tell my friends who went to Vietnam and Korea and all that. I was stationed at Andrews Air Force Base, and because I was of no threat to the other officers, I ran the VIP ward at Andrews
Hmm.
because they were hoping that Nixon would come there as a patient, which he didn't. But
Hmm.
I had patients like Curtis LeMay,
Mm.
various Mrs. General this and Mrs. General that, and diplomats and so on. So it was a totally different experience
Right.
from what everybody else had, and valuable, I think.
Hmm.
Uh,
Interesting.
so I went back to Bellevue Street, and by then the same neighborhood had deteriorated tremendously. It went from the 3-deckers and the matched Packards to a lot of absentee landlords, a lot of minorities, and as I told you, a bunch of Hell's Angels, some of who became patients of mine, which was absolutely a blast. They were really they would protect my car and they would protect my office and so forth.
Hmm.
And so that was an interesting experience. But a number of these people were people that my grandfather had delivered and cared for. My dad had seen some of them, and then I ended up taking care of it. So it was a great continuity that you don't see.
Can I back you up to your grandfather a little bit here? He was doing general, including obstetrics. Did he do home deliveries?
I have no idea.
Okay.
I have
Because
no idea.
it occurred to me when you said you were born at City Hospital, 1938, I believe it was. The it wasn't until about 1940 that over half the deliveries in this country were in a hospital. So
again,
that backed me up.
another
Yeah.
thing I had no familiarity with. So,
Yeah.
or
Okay. Just curious.
uh, and so my career was after Happy Rockefeller and Betty Ford had breast cancer in 76 or so. Suddenly, medical oncology became very busy.
Hmm.
Prior to that, Medicare had no idea what I was doing. And late in the 70s, UMass opened the first hospice in central Massachusetts. And that was a time when Medicare was trying to decide whether to pay for end of life care, hospice type care. So they funded the palliative care unit at UMass, which opened, I believe, in the late 70s. And I became the medical director there in 81, which I was very interested. I was very discouraged with the way terminal care was given in the hospital, all of them. You know, staff would go by and say, "Oh, she's asleep. Let's not wake her up." You know, well, she's
Hmm.
probably in agony there with her eyes shut. So I became their medical director then and stayed until it closed in 85. And then I continued doing hospice part-time in the community until last year, actually. But it was a great experience working there with them. Uh, then I got interested in palliative medicine in the early 90s and tried to start a program at the medical school, but was told, as I told you, push more chemotherapy. We need the money. And
So there's two big things that happened during your career. One is the medical school opened in Worcester.
yeah,
So that was around 1970, just as you're coming into town.
right,
And prior to that, the environment was dominated by St. Vincent's, by City, by Memorial,
right,
and you fit into that environment, and then you migrated over with your oncology and your end of life care to UMass as well, and
right.
incorporated that into your practice. The other big thing that was happening, you alluded to it a little bit by saying Medicare, but there also was a lot of turmoil with regard to health insurance and how things were being paid for, and a lot of experimentation going on with regard to health maintenance organizations, regulating access to care,
Right.
and various other things that were being tried, a lot of trial and error during your career.
That's right. That's right. Which is why I closed my private practice because uh, one secretary could not handle the burden of the incredible number of proliferation of reimbursement programs. And
Hmm.
sadly, we closed. And it turns out, in retrospect, I would have loved to have stayed in private practice.
Hmm. Hmm. And there's an important piece there, which has to do with your professional satisfaction. I think we have to strike a balance between being able to pay the bills and be satisfied with our career, but you're also hinting at the fact that there are components to practice that make for a more satisfied physician.
Yeah, and financially, I made an awful lot more money in private practice than I did when I went to UMass because they kept taking away the things that I was doing to make a living, like doing my own chemotherapy, mixing my own drugs,
Hmm.
soup to nuts. Uh, However, there was a satisfaction of working in the group at UMass with the other oncologists.
Hmm. So the collegiality and the ability to work with others and sort of learn more and exchange ideas was a plus.
But interestingly, I had wanted for years to come here to the Cape to practice. And so I used to because a lot of patients went from Worcester to the Cape and back and forth. And so when I would call down to speak to the oncologist at Cape Cod Hospital, I'd say, do you need another oncologist? They, oh, no, we don't need any more oncologists. When I came here in 2000, immediately they tried to get me to do oncology here. But as I've said before, I did hospice exclusively from 2000 until 2021 when I finally retired, and working in the community in 2 different hospice programs. And also did a palliative medicine practice on Mid-Cape for the last 14 years. So,
Yeah. Now, during your career, what were the major what were the major conditions you treated, and what were the results? How did the results evolve over time?
well, I did some general internal medicine, and so that went as internal medicine would go. Blood pressure and cardiac and so forth. But it became more and more oriented to cancer, and the thing was that we started out doing just simple chemotherapy back in the 60s when I was in training. You had one recipe for Cytoxan, methotrexate, and fluorouracil, and you used that for breast, and then you had the MOP, mustard, oncovin, prednisone, and procarbazine. That was used for lymphoma and for Hodgkin's in particular. And that was the very beginning. And as we talked about that book, the Emperor of All Maladies, that was all just developing then. And then, of course, by the time I left in '99, we were doing a lot better. But suddenly in '99, this targeted therapy that we're seeing now and genetically determined regimens, it just totally changed the picture. And it looks like it's headed in the right direction, but not very quickly.
So during your career, chemotherapy usually meant some form of toxin or antimetabolite, and they were matching the regimen of chemicals to the type of tumor.
Yeah.
And what you saw evolve during your career was both looking at the genetic makeup of the tumor as well as the introduction of various immune therapies.
Well, that hadn't started when I
Yeah, yeah. So those things were just
yeah.
on the horizon.
We
So
did.
a massive change in the treatment of cancer.
Yeah, we were doing bone marrow transplants and stem cell transplants at UMass when I left, but it was pretty rudimentary.
Yeah, and once a patient developed metastases from their tumor, what was their fate generally with the best chemotherapy you could administer?
Well, not much. This is where I had huge differences with other people who were doing oncology, and that was, I likened it to having a set of shelves in your office, and the first line drugs are on the first shelf, and then the second line drugs are, and so forth. And so you'll see the oncologists on tippy toes trying to reach the very top shelf where the useless medications were. And when the patient should, in fact, be headed towards a hospice care, terminal care, and settling his estate and so forth. And so many, of course, some people would not do that, but an awful lot of people would. If they knew the truth about their illness, they would not insist that you poison me again with something else,
Mm-hmm. Well, you bring up another point, and that is that in some ways you specialized in the difficult conversations of discussing death.
My favorite thing. I really enjoyed that, sitting people down, and because like lawyers, we talk gobbledygook
Mm-hmm.
to our patients. And so to sit down with people and have the time to explain to them or to their family members or all of them. In fact, people used to record our conversations so they wouldn't fill the room with guests, and then they'd play them when they get
Mm-hmm.
home. And at first I thought, oh God, this is a meat for the lawyers. But of course it wasn't. People used it and it was very helpful.
Mm-hmm. Mm-hmm. And how did you come upon this? I mean, were you given some sort of exposure during your training, during your early career? How did this evolve as something that
Oh,
you
no
excelled
idea.
in an area that a lot of other people would avoid?
Well, I just happened to like it.
Mm-hmm.
When I was doing the palliative care service at UMass, the most impressive one was a family of about 9 kids, none of whom got along with any of the others. And dad had cancer of the pancreas, and there was, you never saw contention with a capital K. You know, they would, when I asked for an autopsy on the patient when he died, one of the daughters threatened to go up to the roof and throw herself off.
Uh-huh.
So this kind of stuff it was a great challenge,
Uh-huh.
but I really enjoyed it.
Yeah. Do you think, have you seen enough of contemporary medical education to know whether emerging physicians are being trained well enough in this?
I have no real idea.
Mm-hmm.
As I told you, again, my granddaughter, oldest grandchild, is a family practitioner. She graduated from UMass in 2019. She's done a family practice residency in Seattle. She's now back doing an obstetrics fellowship at Brown and going to be going into family practice. And she spent some time with me doing hospice
Mm-hmm.
here on the Cape and going out with our nurses. And I think that was a real eye opener for her. So I'm not sure how much these, and I wonder often how much import the powers that be in medical training education put on this kind of communication. I
Mm-hmm.
don't know. I mean, my granddaughter majored in Spanish in college, and I was told by a well-known friend that you and I have that should never get into medical school. And I
Mm-hmm.
and I majored in English in college and minored in art. And I think that little added uh, uh, thing adds a lot to your.
Yeah, dimension, sure. So, I guess the other question regarding education is it is the medical knowledge has evolved so much since we were initially trained. I was looking at some of my old medical school books the other day, and the genetics was slightly more than a pamphlet, and um, and so I guess part of the question is, just in retrospect, looking backwards, the model we have today, 2 years of basic science, 2 years of clinical, followed by a residency, that has been in place for over 100 years. And I question, whether you think that is still a good idea or whether it is something that you feel maybe would be handled better differently.
Boy, I don't know. I haven't really given that a lot of thought. Remember Index Medicus?
Yep.
Jeez. I remember Boston City Hospital Library going through those. Uh, but I really don't know. My wife had 7 years here on the Cape, and she never met her primary care doctor.
Mm-hmm.
It was just a snafu. All of her care was done by a nurse practitioner. She
Mm-hmm.
took her through an appendectomy. a hysterectomy, a cholecystectomy, everything went absolutely fine.
Hmm.
So the fact is that what's common is common, and what's rare is rare. And I just wonder if the medical students aren't being taught to look for hen's teeth when maybe they should know more about what's common, and then have specialists. You know, we talked about that the other day too. But,
Yeah. Well, if we look at medical research, the idea that took over as the NIH was getting up and running was the idea that you start at the base. You start with the molecule and you work your way up to the cell and the tissue and the organ, and do your research in this very systematic way and develop some discovery. And our medical education is very much the same. We start with the molecules and tissues and work our way up and learn every little detail there. Yet today, there's a lot of thought regarding kind of going in the opposite direction. Start with where you want to be, and then work your way back and find out what you need to know
yeah.
and to the depth you need to know it. And with medical knowledge having expanded the way it is, it's kind of hard to keep up to date as well as increase the scope of care. So that now we're thinking in terms of socioeconomic factors. We're thinking in terms of a lot of other things that were never on the menu before, in addition to the fact that the things that were on our menu before have doubled or tripled in size.
And of
But the
course,
duration of medical school hasn't changed.
now we have this,
Yeah.
and so do you remember how we used to carry in our pocket the Washington manual
Yep.
in our white coat pocket, and how
Yeah.
doggy we would get? And now it's this little thing can answer almost everything.
Yeah.
Yeah.
Yeah. So a greater emphasis really is what you're hinting at here in reasoning and sort of weighing pros and cons of decision making as opposed to rote memory.
Yeah.
And at least when I was in medical school, rote memory got you where you needed to be.
That's what got me through pre-med was,
Yeah.
calculus and stuff. It was just plain brute memory. And when
Yeah.
I flushed the toilet the next time, it was gone.
If you're not using it. And but yeah, so interesting points. Any thoughts? Now you've gone back and forth with regard to satisfaction and frustration and everything in the practice atmosphere that we have today, which basically has seen the practice of medicine migrate towards multi-specialty groups, migrate towards professional management of these groups, and have health insurance that in many ways is attached to guidelines or indications or the like. So we've seen the environment go from where your grandfather was to where medicine was when you retired. Um, any thoughts regarding what you would consider a constructive change in the near term?
Well, I do think that there is some move. Family practice is so undervalued,
Hmm.
and primary care is so undervalued, and pediatrics,
Hmm.
and reimbursement is so poor. And then I'm hearing that some organizations in Boston, for instance, say, my gosh, the primary care doctor in our clinic is the source of all our referrals,
Hmm.
of the orthopedics and the oncology and so forth. And so there has been some move, and I haven't heard this lately, of paying these people what they're worth. Uh,
Hmm.
but I don't have any knowledge. I'm so far out of that realm. I have no knowledge about
Hmm.
how
Hmm.
it really is developing.
Well, the big question right now, I think, has to do with fee for service versus salary.
Yeah.
and you know how tightly to uh, link someone's income to whatever measure of productivity you happen to be using. That is a debate that continues to recycle.
I was at a memorial service for one of our staff members who died suddenly uh, the other day, and I ran into the guy that I partnered with as hospice medical director here in Chatham, and he's he's still seeing 25 patients a day
Hmm.
or more, and you know you don't I don't know how, but for as I think I mentioned before, he is an extremely personable, apparently low key guy, so that I'm sure he's exploding inside, like I'm going backwards here, I'm getting farther and farther behind. uh, that's not satisfying, and so he finally is now going into VIP,
Yeah.
concierge medicine. My wife is now a concierge patient. Of course, that's like going to kindergarten. They feed you, the very basics. Well, vitamin A is this, and vitamin B, which is good. But it's the total opposite extreme, because my wife has essentially no medical needs.
Yeah.
So I don't know, but she loves the accessibility.
Yeah. Yeah. I don't think it's all been settled yet. And as I say, this issue, on the one hand, we've seen more and more people make decisions that they feel are lifestyle decisions regarding relieving themselves of the burden of administration and the security of just having a practice. And on the other hand, I don't know that we have experienced a time in which more people have said that they're burned out and are leaving the profession.
Yeah, I never felt like I was burned out.
Hmm.
And I one of the things, remember Ed Landau?
Yes.
Eddie Landau, Budnitz's nephew, told me early on, he said, if you can possibly do it, don't take all comers.
Hmm.
Don't feel you have to take these people that are going to be annoying to you and you're not going to be able to do much for anyways. And,
Hmm.
and so I did that, and it really worked well. Whereas, so I was not overburdened. Whereas there are some people in my coverage group who I think were churning the mill, so that if you got a snotty nose, you'd come in and be examined and be put on antibiotics,
Hmm.
and stuff, which was just useless, um, in my estimation. So I think I did better by following Eddie's uh, recommendation, that take the people that fit into your demographic.
Hmm. Yeah. Yeah. You are right. I mean, there are times where the physician-patient relationship really doesn't form in a constructive way.
Right.
There's not the level of trust and relaxation and confidence. And in those cases, sometimes it's better to basically allow the patient to move on to someone who might be a better match.
Yeah. Yeah.
Yeah, yeah,
Except that by then the patient has gotten so spoiled that he expects the next doctor to do the same thing.
okay. All right. Well, we've covered an awful lot here. Do you have any final things to say about your career or your family?
Well, as I get older and older and older and older, I look back on it with a lot of pleasure,
Yeah.
uh, and a lot of fun. I had some great experiences in that neighborhood. For
Mhm.
example, uh, down at the south end of Bellevue Street, up across on Chandler Street, there was a bunch of I guess you'd say African-American folks that I cared for.
Mhm.
One of them was a very, very overweight, delightful lady. And she could get a cab to take her to my office, but they wouldn't take her home because they suddenly realized how it was only a half mile and
Mhm.
wouldn't make anything. So I used to put her in at the end of the day
Sure.
and drive her home.
Yeah.
And I would put this huge woman in my Porsche and drive up into the neighborhood. And it was so much fun to watch the reaction of the neighbor as she got out of there. It was an absolute hoot, but it was so much fun.
Yeah.
This kind of stuff. You can't,
That's it. You have control over a lot of the details,
yeah.
and that gives you a sense of autonomy, satisfaction, and the like. Good
And
point.
and and I think the patients, I'm sure, like that too.
Yeah, totally. Excellent. Thanks so much.
You're welcome.